Good morning or afternoon, wherever you're located within Canada. My name is Ted Konya. I'm the Associate Director for the now newly renamed Institute of Health Emergencies and Pandemics. This is the second session of our Catalyst seminar series. Since 2023, our institute has provided over $1 million to research teams at the University of Toronto to support collaborative interdisciplinary research projects that tackle challenges in pandemic and health emergency preparedness, research, and recovery. And so the purpose of these series is just to highlight the great work that our teams have been doing. And each month has a different coordinated type theme. And so this one is on impacts on folks with disabilities. And before we begin, just want to do the land acknowledgement where we acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credits. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And so reflecting on that, if we think about the 92 calls of actions from the Truth and Reconciliation Commission, there's quite a few on health, where it's been acknowledged that previous government policies has created health disparities between Indigenous and non-Indigenous folks. And as we learn today, there's other communities as well with health disparities. And so some of the work that we do for the Institute is to ensure that in the future, that everyone has a right to equitable healthcare. And so the research should be reflected that everybody is able to prosper on this land. All right. And now I'm going to introduce, oh, actually, sorry, I have a few housekeeping items. Real quick, I know I got too many windows open. Captions, if you would like captions, there is an automated captioning button that you can click on. Just keep in mind they are AI generated, so they may not be great, but we will have a future recording, and there we'll have proper captions. We will also be able to share the slides from the presenters to everybody who has attended today, so that will come out within about a week's time. And so the format is we'll have our two presentations, and then we'll end with a question and answer session. By all means, feel free to answer questions throughout the presentations, but we won't get to the questions until both presentations have concluded. So now I'd like to introduce Chavon Niles, who is an assistant professor in the Department of Physical Therapy and cross-appointed to the Rehabilitation Sciences Institute at the Temerty Faculty of Medicine. Her work brings together research, teaching, and community partnerships to ask how health and rehabilitation systems can truly serve those most often left out. She leads the Access Lab, where her team uses storytelling, narrative inquiry, and community-based research to understand how race, disability, migration, and policy shape people's everyday access to care. Her recent studies look at the experiences of Black and racialized immigrants with disabilities during and beyond COVID-19, and in what these stories can teach us about rebuilding health systems that are equitable, inclusive, and grounded in dignity. And now I'm going to stop sharing and allow you to take over, Chavon.
Thank you, Ted. And thank you for that lovely introduction. So I'm just going to share my slides, and in a moment I will get started. So good afternoon, everyone. It's so lovely to be here with you on Zoom on this very, very chilly day. Once again, my name is Chavon Niles, and I'm a assistant professor in the Department of Physical Therapy. And I'm here to share with you some preliminary findings from a study that has been funded by the Institute of Health Emergencies and Pandemics. I'll be sharing with you how this study came about, how it was born in community, and some of the emerging findings from the study. So as I alluded to, this work began in community. Before I took on this role at U of T as a professor, I worked in community. Specifically, I worked in an organization called OCASI, the Ontario Council of Agencies Serving Immigrants, for about 9 years. OCASI acts as a collective voice for the immigrant and refugee serving sector. I had transitioned from OCASI and had moved on to Sick Kids during the pandemic. And OCASI had contacted me in about 2021, I believe, which was I would say, the height of the pandemic. And they said that we are seeing a lot of immigrants and refugees with disabilities, and service providers are really struggling in regards to how to provide services for them now that services are moving online and we need some support. So they asked me if I would be willing to um, speak with immigrants and refugees with disabilities across Ontario. And in doing so, I worked with them to create what was called the Access in Action Toolkit. And in that toolkit, it had the untold stories of some immigrants and refugees with disabilities, sharing their migration stories and the challenges they were experiencing during the pandemic, as well as resources and supports for service providers on how to support this, population that tended to be left out of the conversation. And I would say this experience, in addition to other community engaged work that I have been engaged in, has really shifted the way that I think about accessibility. And for me, accessibility isn't just thinking about the universal symbol. It's thinking about, what barriers might a person experience before coming to our front door. And once they get to our front door, what barriers might they then experience? For me, accessibility is also a relational experience. And that meant that I wanted to shift the conversation around from compliance to understanding that accessibility is about belonging. It's about creating or co-creating a culture of belonging. So the question that emerged from this is, what does real access look like for people that are underserved and under-resourced? And so in 2023, I'm taking you on a bit of a journey of how this study came about. In 2023, I worked within an interdisciplinary team to conduct a study that was funded by the funded by the Rehabilitation Science Research Network for COVID, to really begin to understand the experiences of Black and racialized immigrants with disabilities living in the Greater Toronto and Hamilton area. We wanted to understand their experiences during the pandemic, barriers and facilitators in navigating health and rehabilitation services. And so here are some of the findings that we found from that study. We found that many participants couldn't access virtual services or telehealth because they didn't have access to stable internet connections or OHIP. Others that were covered by the interim federal health program, they received some services, but they couldn't access rehabilitation services that they needed, to maintain a certain quality of life. And they also shared that there was long approval and wait lines. So while healthcare went digital and it was accessible to a lot of disabled folks, for others it was not accessible, especially for those that just didn't have access to the internet, or those that were immigrants and their status made it quite challenging for them to access certain services. What we also found within that study is that people did lose jobs if they didn't qualify for EI or the CURB benefits because they had multiple part-time jobs, or they were self-employed. It was even more difficult to navigate life during the pandemic and maintain housing and support themselves, as well as family members if they had them. Some of our participants we spoke to us about the fact that the dangers around applying for income support. They were told that if they applied for any type of income support like EI or the CURB benefits, it might actually impact their ability to stay in Canada, get their permanent resident status. So that fear actually kept a lot of people from accessing services that they needed. And we saw that same fear actually show up when people were navigating the healthcare system. It wasn't actually until a moment of crisis did many participants go out and seek services, because they were afraid that because they were immigrants to the country, they were going to be seen as a burden on our healthcare system, or it would impact their ability to maintain their status in the country. What participants told us is that while they didn't have great access to formal systems, they actually ended up building their own systems and their own networks. They spoke to us about neighbors dropping off groceries for them, pastors offering counseling, and friends that helped them to interpret medical forms and documents that were really, really inaccessible. So these informal networks actually became the real infrastructure of care, or a term that was coined, I would say, during the pandemic, was we saw mutual aid and mutual care happening at the same time. And what I want you to take away from that, and what participants said it, and what we're alluding to, is that this exclusion wasn't actually random. It's structured through overlapping systems of inequities. I always like to say that inequities are actually built into the social fabric of our society. So it's not it's not that these stories are an anomaly. It's a reinforcement of how systems are designed to benefit people that are part of the dominant group, and those that exist at the intersection of experiencing multiple systems of oppression, they tend to be left out. Those that are navigating immigration systems, income, struggling to maintain stable income, housing, and healthcare. So this brings us to this study that's funded by the Institute for Health Emergencies and Pandemic. This new study builds off of that earlier work. We only interviewed 10 folks in that study in 2023, and it was limited to the Greater Toronto and Hamilton area. And we felt there was a need to further understand and explore the experiences of Black and racialized immigrants with disabilities beyond immediate health concerns. We wanted to look at mental health and emotional well-being, economic and social stability, and the unintended impact of public health responses, and how could then shape post-pandemic recovery and inclusive healthcare reform. Sorry. Okay, so on the next slide, you'll see the methodology that we use. We use semi-structured interviews and narrative inquiry. And I should mention that this study is ongoing right now. We are still conducting interviews. We actually had about 100 people reach out to us to participate in the study. I am the person that has been fortunate enough to conduct the screening for participants to be included in this study. The study is also grounded in critical disability studies and critical race theory, and we're using collaborative analysis. And what that means is that our team, the team that is together, includes people with lived experiences, community organizers, as well as academics that are leading this work. And what we're hoping is that the stories that are shared from this study can guide policy and practice recommendations in the future. I wanted to share with you 3 stories. I think I have enough time. And 3 stories of what's emerging so far. So the first story on your screen right now is the story of AJ. AJ's story captures what recovery looks like when both work and belonging fall apart. AJ came to Canada in 2016 from the Caribbean, and he was motivated by the promise of opportunity, of a better life and stability for himself. He's someone who identifies as having a disability, and he was diagnosed as having ADHD about a year and a little bit ago. Before the pandemic, he spoke to us about building a good rhythm in his life. He had 2 jobs, he had regular physiotherapy appointments that he was participating in, and he had access to community recreation programs that made him feel really at home. But when COVID hit, those programs that he counted on to build a community, they disappeared. He lost his jobs. The programs eventually shut down, and that sense of structure and connection that he had, it went with it. And he says, back home, I always had people around me. Even if life was hard, I felt supported. Here, I worked and I saved. But when COVID hit, it was like everything just disappeared. My job, my routine, my people. The programs came back later, but they didn't look like us anymore. I stopped going because it felt like I didn't belong there anymore. So when AJ says that the programs, it didn't look like us anymore, we were really curious what he meant by that. And what he's talking about isn't about the aesthetics of the program, but he talks about how the culture of the program changed. That program that he felt like he belonged in, the staff changed, and the way the program was delivered changed. So before the pandemic, he felt that these programs reflected his identity, the music, the conversations, and that he felt the people that were part of the program understood his story. But once these programs opened, the atmosphere was different. And in addition to that, Black and racialized participants, people who looked like him, were no longer going to these programs. So even though he was technically included, he met the program guidelines, he was included, He wasn't connected anymore. And when I think of AJ's story, for me, it ties together one of the other aspects of our study that's really important is thinking about the loss of employment and that cultural disconnection that comes to impact our mental health and that fragile sense of belonging that determines how recovery actually feels. He reminds us that access without representation still excludes, and that belonging itself is a form of care. And it's a way in which we ensure that people feel cared for. I'm going to share with you now Dee's story. So Dee identifies, and these are all synonyms that I'm using that participants chose. Dee identifies as a Black Caribbean woman living with chronic pain and depression. And what she calls, and what she keeps, what she told us throughout the interview is that what she has is a pain that people can't see. She came to Canada in 2013 with her mother, believing that this would be a place where she could finally find reliable healthcare and start over. Her mom died during COVID-19, and for her, everything unraveled after her mom's death. Her health declined, her work status changed, and that sense of security that she had is no longer there. She lost her part-time job, and her physiotherapy appointments were canceled because they were then deemed a non-essential service during the pandemic. So and she tells us, when the pandemic came, everything just stopped. My work, my appointments, even the bus I used to take. I was home almost most days with my pain. They told me my therapy wasn't essential, but my body didn't stop hurting. I don't think people realize how that feels to be told your pain can wait. Her story shows us the invisible side of the pandemic. What happens when policies designed for efficiency overlook people's lived realities? These physical pain and became intertwined, and her mental health deteriorated without access to consistent healthcare or income. And she reminds us throughout the interview that waiting is not neutral. That idea of who has to wait for services and who actually gets to access services. And that time of waiting, how long people wait, it reflects who's suffering and whose disability and whose needs are seen as more urgent. And for her, she kept saying, you know, who is visible and who is invisibilized in our health, rehab, and social systems. For us, her story helps us to understand the intersection of mental health, economic precarity, and that systemic neglect during and beyond the pandemic. I'm going to share one final story with you, and this is Law's story. So Law identifies as a Black African man with a spinal cord injury. He uses a wheelchair and he's lived in Ontario since around 2015. He first came as a student and he was full of optimism. He told us, I thought accessibility here would be automatic, that the system always worked. For a while, living in Toronto, that seemed true. But when he moved to a smaller town in Ontario, um, you know, to have what he felt was a need for more affordable housing, the gap between services became a lot more prominent for him. He spoke to us about transit options that were limited, not just during the pandemic, but after the pandemic. He tells us that almost all services, like clinics, community programs, and even local bus routes were closed or the buses stopped running early. And he says, when everything moved online, it was like the country forgot people like me exist. I tried to book my physiotherapy, but the system didn't work with my screen reader. I called the line, but the line was always busy. I gave up. Back home, the roads weren't great, but people helped each other. Here, everything looks accessible on paper, but you realize it's only for some. And as we listen to Law's story, what I want you to think about is, what he's trying to capture in his story with us, what he's trying to tell us about access in Canada, and the fact that for some, access is conditional in who you know, what you know, the language that you speak. Access is also conditional on geography, on income, and helping us to think about who programs are designed for. Law also talked about having a part-time administrative job, and that he found himself to be incredibly isolated without reliable transportation or care. Um, his story is a reminder of the isolation that racialized disabled immigrants experience when we also tell people during the pandemic or public health emergencies to, stay in place, and the assumptions that we make about who can stay in place, who can shelter in place. Um, and the fact that accessibility isn't universal, it's contextual. It looks different in rural and small town areas than what it looks like in larger communities. And so, as I mentioned, our study is still ongoing. I shared 3 out of the 10 stories that we've heard so far from our participants. We're in our early stages of looking at the data, but I just want to share with you what's coming through the interviews so far. And this is from the interviews that we've conducted. What participants have said to us is that the pandemic didn't just interrupt access to care, it exposed how fragile and conditional access already was for many Black and racialized immigrants with disability. If we look at Dee's story, for example, she reminds us that people with invisible disabilities were deprioritized when physiotherapy or services were labeled non-essential. Her pain and her mental health both worsened, but that decision made for system efficiency had real human consequences. Excuse me. Um, Second, employment losses were almost universal, as we all know. For someone like AJ, losing work meant losing part of his identity and also his social belonging. Economic recovery isn't just about making sure people get access to jobs. It's also about regaining connection, dignity, and some type of predictability in people's lives. Third, as services reopened, it doesn't mean that they look the same. For participants in our study, they spoke about how services looked different. AG's comments that the programs didn't look like us anymore captures that loss of what I'm calling cultural safety. And that's a form of exclusion that's harder to measure, but is deeply felt by the individual. A fourth, I want us to think about digital and geographic inequities that ran through almost every single interview that we have done so far. Law's story specifically shows that access to technology and accessible design still depend on where you live and what you can afford. So this promise of online care didn't actually reach everyone equally. I'd like to stress that equality and equity are not the same thing. And finally, across the participants in our study that we heard from, they talked about the emotional cost of isolation. People grieve. They grieve not being able to work, not being able to access health and rehab in the way that they needed. And they also grieve the disappearance of their community, the everyday interactions that make life livable. And so for me, this points to this central theme around, recovery isn't just about accessing medical care. It includes the social, the economic, and the emotional aspects of our life that gets taken for granted. And so, as I was putting together this presentation, I thought about the importance of thinking about not just shifting, the need to shift systems and not people. If you go back to what I said earlier about inequities being ingrained in the social fabric of our society, and if you think about equality and equity are not the same thing, how do we ensure that we're actually moving these systems that were never designed for people that exist at the intersection of experiencing multiple inequities? So some things I'd like for us to think about is the importance of integrating accessibility and equity in emergency and recovery plans. So it's something we do from the very beginning, or we do now, as opposed to when the next pandemic or public health emergency, comes about. Funding community-driven and disability-inclusive health initiatives. So centering those that are the most underserved and under-resourced, and making sure that the services that they have access to is reflective of their lived experiences. The importance of training on bias, especially our implicit biases. As humans, we have biases, and our biases come to inform what gets centered and what does not, how we communicate with each other, and the importance of intersectionality. Remembering that people don't live single-storied lives, and we all exist at the intersection of multiple identities. the importance of prioritizing access, digital access that is accessible and cultural safety together. And so for me, I think about the importance of redesigning systems to be inclusive. So I'm wrapping up, Ted, I promise. So here's what's coming next. We're going to complete the rest of our interviews. Our goal is by the end of this month, and then complete our data analysis, which will give us a more fulsome understanding of our study. We're hosting some knowledge translation events based on this work that I began before this grant. Our first is happening on November 19th. And we're putting together a larger CIHR STEPS team grant to focus on equitable emergency preparedness in 2016. And I'd like to stress what participants, from what we've heard from participants, is that recovery isn't about returning to a normal, the normal that was. It's about building what should have always existed, or what should have existed all along. I want to end by just really thanking the participants, all the people that have reached out to participate in our study, for trusting us in sharing their stories. I want to thank the Institute of Health Emergencies and Pandemics for the funding to do this important research, and the Access Lab in supporting this presentation. And I'll end with one final question for you all today: is how might our health systems change if accessibility and belonging were built into every decision from the start? Thank you. Thanks, Ted.
Thanks, Chavon. And just a reminder for everybody, if you want, you're welcome to enter questions into the Q&A, but we'll get to them after our next presentation. So for now, I'm going to introduce our next presenter, Hilary Brown, who is an associate professor in the Department of Health and Society at the University of Toronto Scarborough and the Dalla Lana School of Public Health. She's cross-appointed to the Temerty Faculty of Medicine's Department of Obstetrics and Gynecology and is an adjunct scientist at Women's College Hospital and ICES. She holds a Tier 2 Canada Research Chair in Disability and Reproductive Health. Her research program examines health across the reproductive life course with a focus on populations with disabilities and illness, health equity, and the social determinants of health. So I'll pass it on to you, Hilary.
Wonderful. Thank you very much for the introduction and for the chance to share our research. So I'll just go ahead and share my screen. All right. So what I'd like to chat about today is a study that we conducted that was funded by the Institute of Health Emergencies and Pandemics, looking at the impact of the pandemic on clinical outcomes of patients with a disability who were hospitalized on a medical service during the pandemic. So just to provide a little bit of context, the COVID-19 pandemic had significant negative impacts on healthcare systems internationally, and a lot of this was related to diversion of hospital staff and equipment from medical services to COVID-19 patients, given the demand for healthcare in this area. But there were a number of indirect effects as well. We heard reports of reduced ability to communicate between health providers and patients due to the use of face masks and face shields. There were also restricted hospital visitor policies that impacted the ability of patients to bring support persons with them to appointments. And there were also reduced access to post-discharge supports, such as outpatient rehab and other interprofessional healthcare services. There have been a number of studies that have looked at the impact of these barriers and disruptions on patient health outcomes among patients who were hospitalized for conditions other than COVID-19. And many of these studies have shown that there have been increases in mortality and other negative outcomes in non-COVID patients during the pandemic. And this is again hypothesized to be due to some of the disruptions that were occurring during the healthcare system during this time. We know that about a quarter of the adult population has a physical, sensory, or cognitive disability, so this makes up quite a large proportion of the population demographic. And as Chavon described in her presentation as well, we know that people with disabilities experience disparities that predated the pandemic in relation to education, employment, and income, as well as housing, social support, and access to healthcare. And many of these disparities widened during the pandemic as well. In parallel, there's growing research showing that the pandemic had a disproportionate negative effect on patients with COVID-19 who had a disability, including elevated rates of in-hospital mortality and other outcomes for patients who were hospitalized during the pandemic with a COVID-19 infection. But what's received less attention is the impact of the pandemic on non-COVID patients with disabilities who were hospitalized. So this was the context in which we conducted our study. And our objective was to examine the impact of the COVID-19 pandemic on the clinical outcomes of patients on a medical service. And we were interested in looking at this overall and then comparing patients with and without disabilities. So I'll give you a little bit of an overview of our study methods. So for this study, we were able to use health administrative data from a research collaborative called Gemini, which is run out of St. Mike's Hospital here in Toronto, but it includes data for most academic and community hospitals across Ontario. So it's a really great resource to be able to understand the clinical outcomes of hospitalized patients. And so for this particular study, we used information on all medical admissions that occurred between 2016 and 2021. And as I'll describe in just a moment, this enabled us to look at outcomes in patients prior to the pandemic, as well as during the first 3 waves of the COVID-19 pandemic. So our study cohort comprised patients who were 18 years of age and older, who were admitted to a medical service for urgent reasons. So these weren't elective admissions, they were urgent admissions, as well as patients admitted to intensive care unit service within the first 24 hours of admission. And again, just to emphasize, these were patients who were admitted for anything other than COVID. So things like acute myocardial infarction, pneumonia, influenza, anything that might require an urgent hospitalization. But again, keeping out those patients who were admitted for COVID. Within this cohort of hospitalized patients, we then identified those with and without a recorded disability. And this included physical disabilities likely to impact mobility, so things like musculoskeletal, as well as neurological disorders, permanent injuries, as well as congenital anomalies. Sensory disabilities, including hearing and vision loss, and cognitive disabilities, including autism, intellectual disability, as well as traumatic brain injury. So we have all of our admissions from 2016 to 2021. And among these admissions, we then divided them up into those that occurred before the pandemic and those that occurred during the pandemic. So the pre-pandemic admissions were from April 1st, 2016 to February 28th, 2020. And the pandemic admissions were those from the day the WHO declared the pandemic to the day that the Ontario government reopened services following the 3rd wave of the pandemic. So that was from March 1st, 2020 to June 30th, 2021. And I'll just say that at the time of this analysis, this was the data that was available. And so we don't have information on the 4th wave of the pandemic and onwards. We looked at a number of clinical outcomes that are available in health administrative data, including in-hospital mortality, ICU admissions, total length of stay, as well as 30-day unplanned readmissions. And again, these are clinical outcomes that we have available to us in health administrative data. So they're overall markers of patient well-being, but don't necessarily get at the full patient experience. So some of the more nuanced personal experiences that Chavon talked about in her presentation, unfortunately, we're not able to capture those in our data, and you'll see how that kind of plays out as I go through the results. We adjusted for a number of covariates that could explain differences in outcomes across groups, both pre versus during the pandemic, as well as in the disability versus no disability groups. So these included age, sex, residence in a long-term care facility, neighborhood income quintile, neighborhood visible minority percentage, admission from the emergency department, the number of hospitalizations in the previous 6 months, biochemical score of illness severity, comorbidity, as well as diagnosis group, which indicated the case mix of the patients. So I won't get into too much detail related to the statistical analysis, but just to give you a brief overview, Our first analysis related to looking at the overall cohort in terms of comparing pre-pandemic and pandemic outcomes. And what we were really interested in being able to do is to predict expected counts of our outcomes during the COVID-19 pandemic based on pre-pandemic data. So it's a bit of a predictive model to be able to understand what we observed during the pandemic versus what we expect to have happened should rates of the outcomes stay constant based on pre-pandemic data. And to compare them, we undertook a number of statistical analyses, including comparing rate differences as well as incident rate ratios. And I'll walk you through those outcomes when we look at some figures. So that's again comparing pre-pandemic versus pandemic data in the overall cohort. Then we were also interested in understanding how things differed by disability status, both in the pre-pandemic and pandemic eras, as well as whether the pandemic had a potentially differential impact on clinical outcomes for patients with disabilities versus without a disability. And to do this, we used an interaction term that estimated the average differential impact of the pandemic by disability status on the clinical outcomes. Okay, so here's an overview of our results. Just to give you a sense of who's in our study, we had an average age of about 68 years of age, with just over half of patients being male. About a third lived in the lowest income income quintile neighborhood, and about a third also had multiple comorbidities. Most patients were admitted from the emergency department, and about a tenth lived in long-term care facilities prior to their admission and had hospitalizations in the last 6 months. And so this gives you a sense that this is, an older cohort, as one would expect in a group of medical service patients. And those characteristics were fairly constant in the pre-pandemic and pandemic eras. Okay, so here's a look at our outcomes in patients admitted to a medical service for a non-COVID-19 condition before and during the pandemic. And you can see the pre-pandemic data on the right-hand or the left-hand side of the graph, and then the pandemic data categorized into wave 1, 2, and 3 of the pandemic. And what we see across these outcomes is that for in-hospital mortality as well as ICU admission, you see a little bit of a separation in the lines in terms of observed versus expected outcomes, where there were slightly higher rates of mortality and ICU admission observed in wave 1 of the pandemic compared to what was expected. And this leveled off in waves 2 and 3, and the differences for length of stay and 30-day admission were smaller than those for in-hospital mortality as well as ICU admission. So that's for the cohort as a whole. Next, we looked at clinical outcomes for patients hospitalized for a non-COVID-19 condition, comparing patients with and without disabilities in both the pre-pandemic and the pandemic eras. And I'll use in-hospital mortality as an example. These are odds ratios comparing patients with and without a disability. And what we see is elevated odds of in-hospital mortality in the pre-pandemic as well as the pandemic era, comparing patients with any disability to no disability. And we see similar types of disparities for cognitive disabilities, physical, and multiple disabilities as well. And same types of patterns across ICU admission, length of stay, and 30-day readmission, to a lesser extent for 30-day readmission. But the main message that we're getting here is that there were significant disparities between patients with and without disabilities, both pre-pandemic and during the pandemic eras for these clinical outcomes. So then the next question is whether the impact of the pandemic on these outcomes differs for patients with and without disabilities. And what we saw in our modeling for these analyses is that, in fact, for the clinical outcomes that we were able to examine, both patients with and without disabilities experienced an increase in in-hospital mortality as well as ICU admission in the first wave of the pandemic. But the nature of the disparity did not seem to be greater for patients with disabilities compared to those without. And again, for length of stay as well as 30-day readmission, the differences between pre-pandemic and pandemic were smaller for both patients with and without disabilities. And this final graph is just another way of picturing the same data as in the previous slide, where again, we see increases in in-hospital mortality and ICU admission in the pandemic era compared to pre-pandemic for both patients with and without disabilities. So what do we make of all of this data? So again, in relation to our overall findings, we're seeing that there is an increase in in-hospital mortality and ICU admission in the pandemic versus pre-pandemic for non-COVID related patients. And when we compare this to prior research, most studies that have examined the impact of COVID on hospital care have examined things like patient care seeking behaviors and admission rates. And especially in wave one of the pandemic, showed a hesitancy among individuals to seek urgent care, probably related to a lot of the public health messaging that we were receiving about the importance of staying home. And only a few studies have really examined the impacts on clinical outcomes, but studies that exist do show increases in hospital and 30-day mortality rates during the pandemic for patients who were admitted for things like acute cardiovascular syndrome, heart failure, asthma, and chronic obstetric pulmonary disease. So again, similar findings to ours, except that we showed that the largest impacts in Ontario, at least, appeared to be for wave one of the pandemic, with some evening out in waves 2 and 3, which suggests that adaptive approaches in the health system did help to mitigate some of the strain of the pandemic on hospital resources as a whole. When we look at the impact of the pandemic by disability status, there's been a number of really important studies describing greater barriers to high-quality hospital care for patients with disabilities during the pandemic, and you heard a lot of that reflected in Chavon's presentation as well. Contrary to our hypothesis in our data, we didn't see a disproportionate impact of the COVID pandemic on patients with disabilities compared to those without disabilities. But I just want to emphasize again that the outcomes that we observed really only capture things that happen in hospital, and they certainly do not capture patient experiences or post-discharge mortality and barriers to urgent care. So we need to keep those limitations in mind. But I think the most important finding of our study is that patients with disabilities experienced major disparities in clinical outcomes across both the pre-pandemic, and the pandemic eras. So again, we didn't see a differential effect of the pandemic on patients with disabilities, but what we did see is that their outcomes were worse across the entire study period, both pre-pandemic and pandemic. And this finding is certainly aligned with literature that shows that patients with disabilities who are hospitalized for conditions like pneumonia and heart disease and other outcomes have worse clinical outcomes than their non-disabled peers. And qualitative research suggests that there's a number of contributing factors, including providers' limited disability-related knowledge, failure to adjust communication plans to meet patient needs, undertreatment of pain, and barriers to post-discharge support. So there's a lot of barriers that patients experienced even prior to the pandemic that have continued into the pandemic years. So I do want to note a couple of study limitations that are important to be aware of. Because we were using health administrative data for our study, we need to keep in mind that disability status relied on the presence of diagnoses that were recorded in health administrative data. So it's certainly possible that we could have misclassified disability status. In Ontario and elsewhere, unfortunately, the only information that we have at a population level on disability is based on diagnostic codes. There is some work being done currently to integrate self-reported equity identifiers, including things like disability, gender identity, and race and ethnicity into health records, but that's not currently being done at a provincial level. And so at the moment, this is the best way that we have to be able to identify disability at a population level. We used a hospital research collaborative for our data, and the readmission data are limited to Gemini hospitals, which are part of the collaborative. However, about 80% of readmissions are thought to be captured, so this is not a major limitation, but something to keep in mind. We had no data on important covariates that could have impacted our results related to things like smoking, obesity, or individual level of socioeconomic status or race or ethnicity. And again, this is a limitation of all health administrative data since our health records don't currently capture these factors. And then finally, as I've already emphasized, we had no information on patient-reported outcomes, including perceptions of the quality of care that they received. However, despite these limitations, I think there's a couple of important implications to take from this work. In terms of the overall impact of the COVID pandemic that we saw on clinical outcomes for the cohort as a whole, I think this really speaks to the importance of adherence to guideline-driven treatment when possible, as well as maintaining access for community members to emergency care when they need it, and making sure to have high-quality education for the public on appropriate care-seeking behavior, including encouraging them to seek care for urgent issues, even during public health emergencies. The disparities that we saw in patients with disabilities across the pre-pandemic and pandemic eras really shows the importance of further research to understand patient experiences, as well as longer-term clinical outcomes, as well as to try to identify more nuanced impacts of the pandemic on care that might not have been reflected in our outcomes. But certainly the disparities by disability status that we did observe show the importance of better hospital and post-discharge supports for patients with disabilities, both during pandemics as well as more broadly. So I'll finish it off there and hand it back over to Ted for the Q&A. Thanks so much.
Great. Thank you, Hilary. So as I mentioned before, if you have questions, feel free to plug into the Q&A feature on Zoom, and then we can get some of those going. While waiting for some to arrive, I think what was interesting, and we didn't plan this, but limitation in Hilary's study on patient experience is exactly what Chavon was working on. So I think it does highlight, the need for the interdisciplinary work and different types of research that can give you different types of information. And I think the other thing that stood out to me was, what was the quote that you had at the end of yours, Chavon? That recovery is not about returning to normal. It's about rebuilding systems that never included anyone in the first place. And so I think Hilary's research had shown that there were issues before the pandemic. They may not have gotten necessarily worse during the height of the pandemic, but going back to before obviously isn't the key. So I think a question for both of you is, do you think the policymakers or the people in charge were aware of these issues? And do you think that there will be change moving forward, and how can we get that change to happen? Whoever wants to tackle it first.
I'm okay starting. So the second question is, could you repeat the second part of your question first?
Oh, more about, do you feel confident that change can happen, and what is needed to make that change happen at a policy system level?
I really think it's important to think about who's in the room, right? Like when these policies are being created, who are the people creating the policies? Are you ensuring that those that are the most impacted, the most that are the most underserved and under-resourced are part of the conversation? You can have policies on policies on policies, but if it actually doesn't meet the needs of your community members, these policies are not going to be impactful. And I would say that a lot of times there is this implicit bias that does exist when we design policies, programs, and just institutions. We make an assumption that everyone has equal access, and rarely do we center equitable access, that understanding that people have different experiences, different bodies and different minds, and need different types of supports so that they can be supported. And I think I was having a conversation with a colleague this morning, and we were talking about, those that were service providers, they're also living through the pandemic. Those that are policymakers, they're living through a pandemic that they're trying to enforce these types of policies. And as you're living through a crisis and you're doing this hard work, there are gaps that exist. So I truly believe you need to have diverse people and perspectives around the table, center community members, learn from this pandemic. This isn't the first and this is not the last, and take these lessons to ensure this doesn't happen in the future. We are hosting an event next week that's funded by the Institute for Health Emergencies and Pandemics, where we're bringing together people with lived experiences, Black and racialized disabled folks, including immigrants, academics, community organizations, and folks from public health. The event is called Collective Futures, and it's really about thinking about lessons learned from the pandemic and what do we do to ensure this doesn't happen before. I think this equity work also happens piecemeal. I don't have a nicer way to say it. And I think that in recognizing that if you actually embed equity into policies, we're less likely to be in these situations.
Yeah, that's really well said. And maybe I'll just add to that. One thing that always strikes me is that AODA, which in Ontario governs a lot of our disability related policy, doesn't actually cover healthcare spaces. There's a healthcare standards committee that's been working really hard to create policy for healthcare spaces, but their standards that they've created are still in draft form and have not been enacted into law or policy. And so I think that's why a lot of this does end up being piecemeal, because it really just depends on individual advocates, individual providers in terms of how willing they are to provide accessible care. So just to emphasize that, in addition to all the important advocacy work, I think there has to be this policy level kind of standard for healthcare spaces and health policies that enables people to have a benchmark to try to meet.
Thanks. So there is a question in the Q&A that I think is similarly related. But do you believe that it's possible to enact policy changes to a scale that would meet everyone's access and equity needs, given the breadth and diversity of those needs?
I can try to jump in on this one. That's a tough question. I think it is very individual, but it's interesting in a lot of the work that we do, and most of my other research is related to reproductive health, but in a lot of the work that we do, we just hear from people. Sometimes it's as simple as just asking people what their access needs are and trying to tailor care accordingly. And it's surprising how often people aren't even asked what their access needs are. So I agree that at a policy level, it's difficult to come up with something that covers everybody and their unique needs. But I do think that, training healthcare providers about disability, what is accessibility, how can you provide accessible care, and reminding them of the importance of asking people about their access needs, I think that can go a long way as well. I don't think that solves the problem, but it's something that's come up a lot in our work.
I think for me, when I hear this question, I think it's a great question. I would say the policies we have in place right now, who do they serve? And what assumptions are we making about um, people's access and equitable needs that they have, right? Right now, I'm so glad, Hilary, you brought up the AODA. The AODA was supposed to be enacted fully in 2025. We're almost at the end of 2025, and it has not been. 1 in 5 Ontarians currently identify as having a disability. The universal symbol for accessibility is a person using a mobility device, a wheelchair. 75% of disability, even more than that, are actually invisible. So, what assumptions do we make about disabilities when they are invisible disabilities? So, I think this is the perfect time, given our commitment, our government's commitment to accessibility and inclusion, for us to look at policies and think about when were they designed, who were they designed for. We also have an aging population. Many people want to age in place. If we live long enough, if we're not disabled already, we're more likely to identify as being a person with a disability. So I'd like to think that I'm also someone that has my heads in the clouds a little bit as an academic. And I do think it's possible that we strive to be barrier free. I don't think it's possible that we're going to be completely barrier free, but we have an opportunity right now, given how, disability, the rate of disablement thinking about the diversity of people that exists, the fact that people are aging, and our government's commitment. And I do believe, and we know this through all the great work that also happened during the pandemic, the more diverse people and perspectives we have around that table, the more reflective we are of the society that we live in, the more likely we can create policies to meet most of our needs. And we can continue to strive to be barrier-free.
Thanks. There's a question for you, Chavon, on finding out information to register for collective futures events. How can they?
Um, so we will advertise. Our roundtable in Toronto is sold out, which is pretty amazing. We're going to have one more in Durham, Hamilton, and we're going up north in the new year. We will start advertising most likely in February. These roundtables will begin again in April. So you can connect with me. Maybe I'll put my email in the chat and you can connect with me. You can also connect with the lab. You can also follow us on social media and we'll be sharing more information.
Okay, thanks. I think we have time for one more question. And it's when you both started this work, were there any implicit or explicit biases that you noticed were reflected in the way you engaged with the individuals? And if so, how did you navigate that?
I'll go first. These are really good questions. I'm a community engaged researcher. I'm a critical disability health equity researcher, and I will never claim to be bias free. One of the things that I do in my work is I recognize that given my own positionality and my own social location, I come with biases. So it's important for me to understand my own social location and how my biases come to inform how I'm making sense of what participants are sharing. So interviews, when we create the interview guides, it's created as a team, the research team, including people with lived experiences and community partners. We come together to create the interview guide. Every research project that I have is interdisciplinary. It's informed and engaged with community members. When we develop our code book or our coding sheet, this is done in collaboration with other team members. We ensure triangulation and we do member checking. We also talk about our biases. We talk about our assumptions and we check in with each other. And biases are always at the forefront of what we do to ensure that we're not reproducing deficit-based thinking in our work. So I would say it's an ongoing process of learning and unlearning. I don't claim to be bias-free, and I think that's probably the most important thing I can do as a researcher. Thank you.
Yeah, thanks. Hilary?
Yeah, I agree. I think that continual learning and checking your biases is so critical. With our study, we had about 750,000 participants in our study, so it's population based. We didn't interview people or survey people, but what we do as community engaged researchers is have advisory committees that include people with lived experience as well as service providers and policymakers in all of this work. And so similar to what Chavon described, we're regularly meeting, we're interpreting the data together, we're trying to sort of figure out, how we come up with messages and recommendations together. And I think that's a really critical part of addressing those potential biases and even in how we share the results. Yeah.
All right. Well, thank you. So I want to thank both Hilary and Chavon for taking the time to present their research today. And as I mentioned, we will be providing the recording and the slides to all of you within about a week's time. And since this is an ongoing series, we have our next session coming up December 9th with on AI and data with Zara and Sweta Provo. Feel free to use the QR code to register or go to our website, pandemics.utoronto.ca, to get information about registering for that and any future events. So we will have this series going on through March. So without any further ado, I'm going to end this session and thank you all for attending and presenting and hope you have a great rest of the day.